We're ready?
Okay. So I know we had a Swan before. This is just like a little introduction to swans. This is gonna just be like the very basic of the anatomy, how it sits. Then we can look at the physical swan itself. And then on the other side of this, I have some like very basic hemodynamics that we can like go through real quickly. So a Swan is also called a PA catheter. They're the exact same thing, so you might hear them used interchangeably. It's essentially a right-sided heart cath. So what the point of it is to get pressures and volume statuses inside the heart. So whenever somebody's going for a right heart cath, basically what they're doing is they're going down to the cath lab, getting a Swan placed, getting their numbers, and then taking the Swan right out. So having one at the bedside is just a continuous right heart cath. So like I said, it obtains cardiac pressures. It is a central line, and I'm going to refer to the heart for like pressures and flows and stuff. So it'll go typically through the IJ like we normally do. It enters through the SVC. It'll go through your right atrium into your right ventricle, and then it sits in your pulmonary artery. So towards the lungs. The artery, remember, it feeds the lungs. And then we'll get a couple of different numbers through it, and when I talk about like the numbers that we get, I can tell you where they all come from. So some key concepts, which I definitely spelled incorrectly, that we like want to think about are your preload, your contractility, and your afterload. You're going to hear me say those three phrases. The basics of them is preload is an indicator of volume. Contractility is like the strength of the heart's contraction. I'm really forgetting all my T's. And then afterload is the resistance against the heart, so a pressure. The easiest way to think about hemodynamics and everything is volumes and pressures. Certain numbers are volume indicators, certain numbers are pressure indicators. And we use both to determine what's going on inside the body and how the heart is reacting to different things. Okay, so that's just kind of like a very brief overview of what the like PA catheter is. Now the setup for it, okay. You're gonna have two pressure bags with it because you're getting two different pressure readings. You're going to be able to get a CVP off of it, and then you're also going to be able to get your pulmonary artery pressure. So two pressures, two pressure bags. They get set up the exact same way that a regular pressure bag gets set up, just like an A-line, which we're all very, very familiar with. The only difference is what they're connected to. So this little yellow guy is the Swan itself. It's got, oh my goodness, a lot of different connectors to it that all like help measure different things. Okay, so the Swan itself is yellow. It'll come in this, oh goodness, sterile container to help keep the catheter itself sterile, because if you think about it, this is a really, really long catheter, and I'm not like a really, really long human. So typically only this much actually sits inside the person, whatever, you know, however deep it gets to the heart and then sits in the PA artery. The rest of it is still outside of the heart, but this is one big catheter, so we keep it covered to help with infection prevention, okay? So any Swan you'll see will have this kind of clear protective catheter, and this is all sterile and to help keep it like closed and inside of somebody. The back half of it is the part that we as nurses will see the most, and it's kind of like the most intimidating. The best thing about PA catheters is everything is color coordinated. So what is on here is what it is going to be on the monitor, and it's pretty standard across the board, like everywhere you go. Anytime you see blue, think CVP, just like if you were to hook up a regular CVP through like your regular IJs on your monitor, it's blue, 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 always going to be blue. And then yellow is always going to be your pulmonary artery pressures. So if you just follow your like tubings and you're like, I don't know how to hook this up, blue is your CVP, and then the yellow is going to be your pulmonary artery. So this all goes down. If we were to feel this, you have a bunch of different like exit points. So your pulmonary artery, since that's the end of it, where it sits in the heart, it's going to be the end of the catheter. And then there's like a little hole right here, which is up a lot higher, which is going to sit where your CVP is. So your blue will terminate there. You also have this red one that is for inflating the balloon at the end of the pulmonary artery catheter to get your wedge pressures. Now, as you can see, it's a really tiny balloon, kind of like a Foley would be. This is how we get certain wedge pressures. However, when we wedge it, it fills up the entire pulmonary artery and it occludes it. It's also called an occlusion pressure. So you don't want this balloon inflated because you're occluding the artery, and that means your pulmonary artery is not getting blood flow. So it's really, really easy to cause ischemia or actually rupture depending on how fragile the person's veins are. So even though this is connected, there's like a little locking mechanism here. Us as nurses, this balloon should always be deflated, and this should always be locked. It's a little red arrow. If it's in line with the arrow, it is unlocked and you can inflate and deflate. If it is not in line, you won't be able to inflate the balloon. Like I said, it's pretty dangerous to have this balloon inflated. So one of the best things you could do is always keep your syringe empty and your locking mechanism locked. Because let's say you're turning a patient or something like that, if it accidentally gets unlocked with an empty syringe, there's no way to accidentally inflate that balloon. Whereas if you were to keep the balloon or keep the syringe open and like with air in it, if you were to accidentally unlock it, you could very easily accidentally inflate that balloon. And like I said, that can cause a lot of problems. The other like safety mechanism of this is a special syringe that comes in your Swan kit. It is locked at 1.5 milliliters. So you cannot physically fill it up with any more air, because that's as much as this balloon was. If you were to use like a regular 3 milliliter syringe and accidentally put too much in it, you could rupture the balloon, hurt the patient, rupture their pulmonary arteries. And because it's a pulmonary artery where it is, it's pretty much impossible to get to. So if that pulmonary artery were to rupture or like dissect or anything like that, it's pretty impossible to stop that kind of bleeding. And it's an artery, so it's going to bleed pretty quickly, pretty fastly, quick, and like into their lungs. And there's really no reversing it. So that's why we don't want to inflate the balloon on accident. Or really the only person who should be inflating balloons is an attending physician. Okay? Yeah, so that's the red
And what do you call that, inflating the balloon?
It's called an occlusion pressure or a wedge pressure, okay? So when we set this up, this all comes separately. There's like 18 different pieces to it. The doctor will work on inflating it. We've kind of determined that he's the one to prime it. So what we as nurses do, we'll set up the pressure bags and then just like an A-line, hand for completion. The two parts that get it are the two pressures, so your CVP and then your PA. And then we have to set up the cardiac output part of it. So, on your CVP line, and CVP is always blue, your pressure bag, we're going to add two special things to it. So this is a regular pressure end. You're going to add a stopcock for the ability to do cardiac outputs. And then there is a special temperature reader piece. It's a little triangle or a T with a connector for the temperature probe. This is how the Swans can read cardiac outputs, something called thermodilution. So basically what we do is your pressure bag gets hooked up to the stopcock, and then you've got your stopcock, you've got your temperature reader, and then it'll go to your CVP portion of your Swan. The temperature reader, we have special little probes here for it. So it's your dual temperature probe one. Your little clamp guy fits right on to the temperature probe. It just like clicks right on. And then the other locks in to the one last probe part that we have. It's pretty hard to miss them up. There's only one thing that connects to this. And this is just like the brain reader. It's how it does all of its calculations and sends all of the information back to the monitor, okay? I'm trying really hard not to break the little spokes in there. It's very delicate. So when you set it up, you're gonna have 4 ports to it. Okay, these are like a little complicated. So now it's all set up. The PA portion of it is just gonna read continuously, just like an A line does. Your CVP portion of it will typically read just like a CVP would, as long as the stopcock is off to the syringe. When it's time to shoot for cardiac outputs, this is why we have the stopcock on here, okay? The way that thermodilution works, remember how I said this is the temperature reader. So it's literally reading the temperature of the saline that's going to flow through it. What the Swan does is it senses the temperature from the time of the CVP or the proximal port to the distal port. And it can take the amount of seconds that this much colder fluid, right? This is room temperature, I'm not room temperature. So it can sense that temperature difference. And it does a calculation for how long it takes that colder temperature to reach from one end to the other end of the heart. And it does a fancy little calculation to determine, based off of how fast that's going, is how hard the heart is contracting. And that's how you get your cardiac outputs. So that's why we call it thermodilution, is thermo, temperature, dilution, water, okay? So when it comes to actually do the thermodilution, the cardiac output reading, there's a button on the monitor that'll literally say obtain cardiac output. You hit the little button and it'll say ready for flushing or something along those lines. The syringe and the stopcock is to keep this closed. I know in some of the things it'll say have like saline or something like that. If you have a stopcock and a syringe, all you do is you would shut it off to the CVP line and you would flush your saline into your syringe till you have the 10 milliliters. This way there's no disconnecting. You don't have to take it off. You don't have to put it on. It stays a closed system to help prevent infection, okay? So that's why we always suggest just a 10 cc syringe on here. When you're ready for your cardiac output, you would turn it off to the pressure bag. It would say ready for flushing. You flush hard, fast, and consistently, because remember, it's reading the temperature through there. So if you're like jam stopping in your saline, it's also going to jam stop through the heart, and then it's going to mess up your cardiac output reading. So you want to do it at a consistent pressure and pace, as like fast as possible, okay? And then you just close it back off to the syringe so that your brains can read the pressure in the monitors and stuff like that. It'll give you a number, hopefully somewhere between like 6 to 10, 6 to 8. And what you'll do is 3 of these in a row, just because there's always going to be a little bit of a difference. Sometimes you'll get wildly different numbers, and you just take the average of the 3, and that's your cardiac output, okay? That was a very, very brief and quick explanation on cardiac output and thermodilution, okay? And then everything else you'll get CVP numbers for. Okay. Does anybody have any questions about the physical Swan itself?
You can infuse fluids through one of the ports, a couple of ports?
So this Swan in particular does not have a med port through it. Some Swans, and I think the Swans that we actually have in our kits, this is like an old expired one,
Sure.
will have an additional white port that is your med port, okay? It'll say something either proximal or mid, and it'll be somewhere in between there. I think it's typically more proximal so that it doesn't interfere with those thermodilutions. And then meds will go through the white port of that. These are also, oh, there's the introducer.
There you go.
When it's like
What I was
in
looking
the person, oops, Larry, don't take it off the ground. When we like go to access it, it'll be inside one of these things. This is what we actually access the IJ or the subclavian with. And the doc, when they're inserting it, will actually feed it through there. And these introducers have a side port which you can infuse medications through, because the introducer, as you can see, is a lot shorter. So it's essentially just like a regular IJ. It's just a central line. Depending on how much bigger the introducer is than the Swan, you may or may not be able to get blood off of it. Typically, they don't love when you get blood off of these things because there's a chance that you like suck it out of place. So depending on who your physician is and how desperate you are for lines, a lot of times they don't even like if you put meds through here. It just kind of depends, okay? So that is the Swan itself. Some of these have an orange port where you can put like transvenous pacers through, but all of them will have the basic yellow, blue, and then basically the measuring ports. Okay? So that's the physical Swan itself. Any questions? No? Okay.
That sounds good.
And we can talk about like waveforms. There's all sorts of things with the physical stuff. But what I kind of really want everybody to know is the basics of hemodynamics. I know this looks really intimidating. These are the numbers and the information that we get from a Swan, okay? So we would get a CVP, also sometimes known as a right atrial pressure, the pulmonary artery pressure, a pulmonary artery occlusion pressure, or the pulmonary catheter wedge pressure. Wedge is like the old school term for it. You'll see occlusion pressure, especially if you're doing like any CCRN studying. They will pretty much exclusively call it PAOPs now. Your cardiac output, your SVR or your systemic vascular resistance, and then your SV or your stroke volume. Okay, so CVPs, and like I said before, the easiest way to think about it is this a volume number or is this a pressure number? And I put V's and P's for which is which, so you can look at it later. So a CVP, or a right atrial pressure, is basically the preload. So it's an indication of volume, and it's the overall volume indicator. I really need like a flip board. So because of where it sits, it'll sit either in the SVC or like right in the right atrium. So it's how full it is, how much stretch there is caused by the fluid. And so that is a preload number. So it's how much fluid's inside, so how much the heart will be able to stretch around that fluid. You'll hear docs talk about like the rubber band concept. That's what that is. It's preload, the ability to stretch. If there's not something forcing it apart, you're not going to be able to like contract as well. So your SV or your CVP, right atrial pressure, they're pretty interchangeable because they're so close. And if you like think about the heart anatomy, there's not a valve in between your SVC and your right atrium. So they're pretty much the same. I'm sure cardiologists would like roll over and hear me say that, but to nurses, they're the exact same. So the typical number is 0 to 8. We're pretty familiar with CVPs, I feel like, around here. It's a pretty common number. Things that can increase it is anything that's going to increase your volume. So think of like your CHF patients, your ascites liver failure patients, your dialysis patients who skip dialysis. They have a lot of volume inside of them, so their CVP is going to be higher. You'll also see CVPs increase when people have right ventricular failure. Because if you always think about a heart, this is going to be a lot of spinning, if it's not going forward, it's going to go backwards, right? So if our right ventricle is not squeezing forward, it's not getting that blood forward, where is it going to back up to? Is the right atrium. So that CVP pressure will start to go higher. So if you see people with like a right-sided MI or cardiogenic shock that's like all over, they'll have higher CVPs because that volume is not getting pushed forward, so it's just sitting back here. So that's when your numbers will go up, okay? When it goes down, CVPs are a volume number, so anytime you lose volume, hemorrhagic shock, people who are really, really dehydrated, any kind of volume decrease will decrease your volume numbers. Your pulmonary artery pressure, just like it says in its name, it's a pressure reading. And just like your A lines, think is your radial artery pressure, right? It's your radial artery. This is a pressure in your pulmonary artery, so it's going to look like a blood pressure number. There's going to be a systolic, there's going to be a diastolic, because it's a pressure number. So we're pretty familiar with it. It's just going to be a lot lower because your lungs are a lot more delicate than the rest of your body, so you don't need a blood pressure of 160 in your lungs. They're tiny, delicate things really close to the heart. It's going to be a lot lower. So a typical pulmonary artery pressure is going to be somewhere 15 to 30 over 3 to 12. Like I told Sarah before, I'm really bad about remembering ranges, but I'm okay with remembering one number and kind of going around that. So I always think it's about 20 over 10 plus or minus a few, you know? So if you kind of remember that, that helps keep it in the middle, and then your map is around 10 because it's a blood pressure, you're going to have a map as well. So your pulmonary artery, things that are gonna make the pressure higher is any kind of lung issue or condition. Pulmonary hypertension. What's hypertension? Hypertension literally is high blood pressure. Pulmonary hypertension is high blood pressure in your pulmonary system. So anytime these numbers go up, that's what pulmonary hypertension is. So things that would cause that, PEs, think about like your really bad COPDers. There's a lot going on inside of their chest. They're going to have high blood pressure inside of their chest. And then same thing, if it's not going forward, it's going backwards. So if your LV, your left ventricle, is not pushing blood forward, it's gonna go backwards. And what's behind the left side of the heart? The lungs. Okay, so if you have somebody who's in really bad left-sided heart failure, you know, we think, and they're like, you listen, they have crackles in their lungs because it's not going forward, it's backing up. Same concept, just the number side of it instead of like the assessment side of it. Okay, there's nothing really that makes it lower except for just like overall volume loss. So you don't really have to worry about that. Okay, so then our next one is our occlusion pressure. This is a volume status, really. It's essentially the CVP of the left side of the heart. That's like the easiest way to remember it and like think about it. It's a little bit higher because it's closer to the other side of your body. And what's going to make it higher is left-sided heart failure. Just like right-sided heart failure makes your CVP higher, left-sided heart failure is going to make your wedge pressure higher because it's just your CVP of the left side instead of the right side. So left ventricular failure, tamponade, squishing on it, cardiogenic shock where your just heart doesn't work very well. What's going to make it lower? Again, volume loss. It's a volume indicator essentially, and sepsis, because we know in like septic shock or distributive shock, so anaphylaxis, that kind of things, your whole volume just kind of drops out. So like I said, just so you have a little bit more of a visual of this, your pulmonary artery pressure goes to your lungs. This is your occlusion pressure. It's essentially the preload of your left side, okay? So if your left side is not pushing things forward, so you have left ventricular failure, MI patients, cardiogenic shock patients, your ventricle is not working very well. So what's behind your ventricle? Your wedge, your right ventricle or your wedge pressure, okay? Does that make sense? The wedge is like a little hard conceptually because even though it's not sitting in your left side, the way that it occludes it, when you occlude it, it basically takes the lungs out of the picture. So bloop, it like looks through the lungs to the left side of the heart. It's an estimation, so there's a couple of things that make that not so accurate, but for our purposes, it's the left side of the heart. Okay. Cardiac output is probably the one we're a little bit most familiar with. It's how hard the heart is pumping, what the contraction is for it. So we should view it more as a pressure reader of it. A regular cardiac output is 4 to 8. You'll also hear the phrase cardiac index. When something is indexed, it just means it's taken to the person's body habitus, because obviously my body habitus is a lot less than somebody who's 400 pounds. So somebody who's 400 pounds has, 350 more pounds for their body to circulate and to perfuse. So they're gonna need more effort than somebody who's like 100 pounds. So when something is indexed, it basically takes the body surface area and factors that into it. So an index is like a little bit more individualized than the cardiac output, okay? So the cardiac output is how hard the heart is pumping. Things that increase it is anything that improves contractility. Epinephrine, norepinephrine, milrinone we give that improves contractility. Digoxin improves contractility. So anything that makes the heart work harder. Actually, in early sepsis, you'll see people with increased cardiac output because it's a compensatory mechanism. If there's one formula every nurse should ever memorize, it's this one right here. Your cardiac output, when boiled down to it, is your heart rate times your stroke volume. So how much times how fast equals like the force of it out, okay? So if you think about sepsis, what happens in sepsis is you dilate out, your blood pressure drops out. But what's one of the very early warning signs? Heart rate over 90, right? That's our SIRS sign, because your heart rate is compensating for that infection, for that loss of volume, essentially. So in early sepsis, where we have those high heart rates, we'll actually have higher cardiac outputs, as opposed to like really late sepsis where they're like just like done and their heart rate's back down to 60. It can no longer compensate, and then their cardiac output will drop. So your cardiac output will be low in cardiogenic shock, post-MI, late sepsis, or severe volume loss, because stroke volume, if you don't have volume, this whole equation will get lower, okay? And again, for like cardiogenic shock and MI, the myocardium itself just gets damaged and can't work as efficiently, okay? Okay, so I'm blazing through these. Your SVR is your systemic vascular resistance. This is a reflection of how the veins are like clamped down, how they're pushing back against the heart, or basically how hard does the heart have to work to overcome and to perfuse them. If you think about the veins as tubes, right? If you were to like blow water through like a really, really tiny straw, you're gonna have to use a lot of force to get a good volume of water because it's so tiny. As opposed to a slightly bigger straw, it's gonna be a lot easier to move air or water through it. Same thing with this, except for our veins are those tubes. A normal number is this. Again, this can be indexed because obviously the size of the person is going to affect how much resistance against it. Somebody who's 400 pounds is gonna naturally have a lot more resistance than somebody who's 100 pounds. So anything that increases it is gonna be anything that clamps down on the veins and the arteries and things like that. So phenylephrine or Neo, what that does is it basically clamps down on it, it contracts it. Levo and Epi, they clamp down and it contracts on it. Midodrine is a huge one. Midodrine is basically oral phenylephrine. It clamps down on it. So remember, anything that clamps down, the heart is gonna have to work harder to overcome that. And then, I don't know why I wrote hypovolemic shock there. It'll actually be lower unless it clamps down. Early hypovolemic shock, it'll when you like hemorrhage out, your veins actually clamp down. Whereas like sepsis, what happens in your veins is they dilate out. So it's going to drop your SVR. You're gonna have very low SVRs in sepsis. Vasodilators, nitroglycerin, that dilates you out. So anything that dilates you out is going to drop that resistance. And like an anaphylaxis is a distributive shock that spaces you out. A very like shortcutty kind of way to wrap your head around SVR think about your blood pressure. The higher the blood pressure, the more resistance the heart, right? It's a lot harder for the heart to push against a diastolic of 120 than it is to push against a diastolic of 80 or 40 or something like that. So even though they're not quite the same thing, they work very, very similar. Unless you have like really bad like cardiac problems, they're pretty much the same thing. Your SVR and your blood pressure are very, very similar. So they're both pressure numbers and they're both resistance to the heart itself. And then the final one is stroke volume. So this is the volume of blood that the heart is pumping out beat to beat. So the physical amount. So it's a volume indicator. Which is 60 to 100, that's the normal amount, milliliters per beat. The SVV is, you might hear us talk about this, especially like in AFib, it's the stroke volume variance. So what that variance is what is the difference in that stroke volume from beat to beat? Things that will have high stroke volume variance is AFib. Because AFib is so irregular, the heart has different diastolic times. And you know the heart fills during diastole. So if you have one diastole that's really short, you're gonna get less volume to pump out than in a time where you have diastole that's a lot longer and you have more fill time. So if this were like an A-line tracing, we can see that this is a good beat, this is a lower beat, we have a long diastole here, this is a nice big beat. You see how short this diastole is, so you're gonna have a lower, you know, systolic pressure. This difference is what we would call your SVV. So AFib is notorious for having a really bad SVV, or if somebody is having really bad volume loss because there's just not physically enough blood for the heart to consistently pump out. So like your hemorrhagic shock patients, your really bad, sepsis patients, they'll have high SVVs. So when somebody has a high SVV, that means there's a lot of variance beat to beat to beat. So we either need to do better rate control or they need more volume. That is it. So that was a lot in a very short period of time. I do not expect you guys to remember it all.
But we haven't.
Yes.
Very precise, like direct to the point.
Okay.
Yeah, this way.
And these are pretty like complicated like concepts, so it's okay if you like don't quite understand right away. A lot of this takes a lot of time and staring at, and especially if you don't like work with it all that often. So if you have any questions, let me know.
There's actually like the medicine part of, it's like saying